Painful peripheral neuropathy, diagnosis, and treatment. Let's get started. Peripheral neuropathy is common. It is estimated that 15 to 20 million Americans over the age of 40 years have a diagnosis of some type of peripheral neuropathy. A combination of detailed history physical examination in tandem with laboratory studies will lead to etiology in about two-thirds of cases. However, the remaining one-third of cases are idiopathic or unknown in origin. The most common causes of non-idiopathic length-dependent peripheral neuropathy are diabetes, prediabetes, and alcohol. Other important causes to consider include vitamin B12 deficiency, paraproteinemias, chronic kidney disease, and chemotherapy. The management usually changing and multi-approach or dimensional. So this is the peripheral nerve. And I would like to pay attention here to the unmyelinated nerve and myelinated nerve. So the myelinated nerve, we will call it from now on the large fiber because it's larger, and the unmyelinated, the small fiber. And why this is important? Because the large myelinated fibers usually carry the pressure and balance, and when they get injured, the symptoms usually present numbness, tingling, poor balance. When you want to examine them, specifically, you will need to check the ankle reflex, vibration, monofilament proprioception. And for the small myelinated fiber, on the other hand, these are more nociception and protective sensation. So the symptoms usually pain like burning, electrical shock, stabbing, and for examination you need to check for temperature and pinprick, which we will cover in more details in a minute. So causes, the most common causes, as I said, diabetes, even pre-diabetes, vitamin deficiencies, B12, carcinoma, chemotherapy. Less common causes, chronic kidney disease manifests as uremia, connective tissue disease, chronic liver disease, malabsorption like celiac disease, HIV, Lyme disease, paraproteinemia like lymphoma, Hodgkin or non-Hodgkin, multiple myeloma, immunoglobulin deficiencies. More rare causes like porphyria, hypothyroidism, acromegaly, and erythromyalgia, and etc. And when we consider or find a patient with peripheral neuropathy, it's extremely important to look for medication and toxins that can cause peripheral neuropathy. So, for example, if your patient take anti-epileptic like phenytoin or lithium, that can be a cause there. Some tuberculosis medication, leprosy medication like dapsone, chloroquine, cardiovascular medication, hydralazine, statin, also interestingly can cause peripheral neuropathy. Chemotherapy, a lot of them, and metals, solvents, etc. Here I have even a longer list for you to keep in mind. Check this medication. Make sure the patient is not taking one of these medications. Now, how peripheral neuropathy present? Obviously, it's a chronic condition. It's a progressive in general. So there is a heterogeneity in presentation, the disease course, and prognosis. And the following neuropathy characteristic must be assessed in every patient. So does the patient have sensory symptoms, motor, autonomic symptoms, which we'll cover in details? Is it a lengthy versus non-length dependent progression of symptoms? Is it symmetrical, not symmetrical? Is it mononeuropathy versus polyneuropathy? And typically when we're talking about peripheral neuropathy, we're talking about polyneuropathy here. What's the time course? Is it fastly happening or is it over many years? So peripheral neuropathy can affect any of the three main component of peripheral nerve: the sensory, the motor, the autonomic. And depending on which one of these nerve fibers are affected, a patient can present with a wide variety of clinical signs and symptoms. Most neuropathies are symmetric. The presence of marked asymmetry warranted further workup to exclude etiologies that require prompt treatment, like vasculitic neuropathy. The sensory symptoms, you get numbness and paresthesia, of course, with a neuropathic pain. And neuropathic pain, typically the patient will say burning pain, sharp pain, electric pain, but mainly burning pain in the feet and hands with numbness and paresthesia. When you have a damage to a small fiber, usually, as I mentioned in the previous slides, present with numbness, tingling pain, lack of temperature perception in a stocking glove distribution, while the damage to the large fiber can result in balance deficiencies, gait issues, ataxia, and uneven fall. The motor symptoms usually manifest after sensory symptoms and occur due to large diameter motor fiber nerve damage. So patient always should be asked about even subtle motor strength concerns. For example, difficulty standing up from a seated position, climbing stairs, or dragging their feet when walking. It's important to determine whether these symptoms are persistent or induced by physical neuropathy. Typically, peripheral neuropathy give you a persistent symptoms, um, while symptoms that induced by activity, typically walking, it can be claudication, whether it's vascular or neurogenic claudication. The presence of isolated weakness without any sensory complaint is unusual in slowly progressive neuropathy and may warrant expedited workup to look for etiologies that only target motor nerves, like multifocal motor neuropathy, ALS, amyotrophic lateral scoliosis. Autonomic symptoms can also occur, like, for example, orthostasis, postural dizziness, constipation, diarrhea, dry mouth, eye, and skin, temperature dysregulation, erectile dysfunction, bladder dysfunction. So keep that in mind. Ask the patient about that. In isolation, these symptoms are nonspecific and are not necessarily related to a neurogenic condition. However, the presence of multiple autonomic symptoms along with sensory and or motor complaints require further workup to rule out atypical neuropathies with predominant autonomic involvement, like amyloid neuropathy. The time course is also extremely important. So if you have a patient that the story happened rapidly, in less than 6 months, symptoms progress, gait issues, then keep in mind that cancer can be the cause. So more targeted work up toward neoplastic cause or inflammatory, certain inflammatory causes. While on the other hand, chronic, slow, progressive neuropathies are typically associated with metabolic causes such as diabetes, prediabetes, and can be managed in a primary care setting. Inherited neuropathies are also slowly progressive, but symptoms usually start in childhood. So, features that are suggestive of hereditary neuropathies include early onset symptoms such as clumsiness, exercise intolerance, delay in reaching milestones, presence of hammer toe and high foot arches, and a slowly progressive neuropathy that may include distal motor predominant symptoms. So always ask your patient about family history of neuropathies, either symptoms or diagnosis. When you examine the patient, you need to do a focus examination because you want to determine the pattern of sensory and motor involvement. So sensory involvement for peripheral neuropathy, typically they are not dermatomal. It's not like radiculopathy. You can differentiate. This is like moving with this dermatome versus this dermatome. With peripheral neuropathy, usually it's non-dermatomal. The symmetry, peripheral neuropathy usually is symmetric. Again, we are talking about polyneuropathy here. And you check the reflexes, and then whether the findings are restricted to a distal segment like toes, fingertip, or whether it has progressed more proximally. And then you do inspection. So when you do inspection, look at the four extremities, not only the affected limb or limbs, and you look for muscle atrophy, hair loss, ulceration, contraction. And then certain hereditary neuropathies can present with high foot arch, and we call this pes cavus, and the hammer toe. And then chronic trauma signs from loss of small fiber pain sensation can lead to visible joint deformity and foot ulceration. Often the patient don't remember even how they injured their foot. Now, in more advanced disease, you get something called Charcot neuropathic arthropathy. So, for example, this is a case of advanced alcoholic peripheral neuropathy. This is how they look like. Look at the curvature of the foot and this massive deformity. Then do motor examination. So again, it needs to be focused. You check muscle strength, and you need to be consistent by using your method, because this is important when you reevaluate the patient for disease progression. And of course, you need to examine the upper and lower extremities, even though the patient have, for example, only lower limb symptoms. When you do examination, it needs to be comprehensive examination. So upper extremities, check all the muscles. Lower extremities, also check all the muscles, the hip flexion, extension, knee flexion, ankle dorsiflexion, plantar flexion. And it's extremely important to observe the patient gait to determine whether there is ataxia or subtle weakness like foot drop or while walking. Then do sensory examination. For the sensory examination, again, for small fiber, that's pain and temperature. Large fiber, that's vibration and proprioception, should be tested. And this can determine the extent and the severity of neuropathy. So, for example, absent proprioception at the ankle suggests a more severe neuropathy than decreased light touch at the ankle. An effective and efficient method of assessing a small fiber sensation is evaluating pinprick sensation with a safety pin. Examination should start distal at the patient toes or the area of reported sensory deficit, poking every few centimeters with the sharp end of the pin and moving proximally until an area with perceived sharp sensation is reached. With a length-dependent neuropathy, there is often a specific level more proximal on the leg where the pinprick sensation become more pronounced. This is a useful method to objectively document symptoms progression over time. To assess the large fiber sensation, you need to check vibration using 128 Hertz tuning fork, with one end of the tuning fork placed first on the distal joint of the great toe. The examiner should support the joint underneath to feel the vibration simultaneously, and should ask the patient to indicate when they stop feeling the vibratory sensation. If the patient cannot feel the sensation at the toe joint, move stepwise to more proximal bony prominence like ankle, shin, etc. until vibration is perceived. Repeat this process in the upper extremity, starting with the distal phalanx. Vibration perception duration less than 10 seconds in lower extremity is considered abnormal in patients younger than 65-year-old. In up to 1/4 of people older than 65, and in 1/3 of people older than 75, absent vibration at the great toe can be normal. Therefore, decreased vibration sensation in isolation should not be interpreted as neuropathy in older people and should prompt further examination of other sensory modalities. If vibration examination cannot be performed, then you can do proprioception. And this is usually can be tested. Ask the patient to close their eyes, and the examiner slowly move a patient joint by holding the side of the great toe upward and downward. Inaccurate joint position sense patient indicate the great toe is up when it's actually going down, or requiring large movement of the joint, more than 50% of the range of motion of the natural joint, before proprioception sense is realized, are indicative of large fiber dysfunction. And then for screening, which I will cover in the next slide, we use monofilament. So reflexes, you need to check upper and lower reflexes. A common finding in length-dependent peripheral neuropathy is a reduced or absent ankle reflex. Asymmetric reflexes between the right and left sides and diffuse hyporeflexia or areflexia are concerning for less common neuropathy etiology, such as demyelinating neuropathies and mononeuritis multiplex. As with other aspects of neurological examination, abnormal reflexes alone are not diagnostic of any particular etiology, but rather should be used in conjunction with other findings to support a suspected neuropathy diagnosis. In this slide, this is called the red flag symptoms and signs in peripheral neuropathy. So if you see motor predominant symptoms or sign, or rapid progression less than 6 months, or non-length dependent, or prominent autonomic symptoms, or early proprioception loss, ataxia, or positive Romberg, these are serious symptoms and signs and require more urgent and extensive workup, preferably always with a neurologist. Now, talking about screening method, the most sensitive screening method for neuropathy include monofilament examination and tuning fork vibration test. So, situation why you need to routinely screen for peripheral neuropathy in patient, for example, with diabetes, right? So, the monofilament testing involve applying 10-gram monofilament on the dorsum of the great toe and assessing for light touch perception. The 128 Hz tuning fork is recommended to screen for abnormal vibration perception as described in a previous section. A combination of these two methods represent a sensitive and specific strategy for diabetic neuropathy screening. So finding of decreased light touch perception and decreased vibration perception on screening has a specificity and sensitivity of almost 90% and 86% respectively for peripheral neuropathy. So we're done with the examination now. Let's talk about diagnostic workup. The initial test you need to do, the CBC and CMB, hemoglobin A1C and fasting glucose, especially when you know that diabetes account for about 50% of all cases of peripheral neuropathy. If these tests are normal, then you need to check the 2-hour glucose tolerance test because it has higher sensitivity, but this, of course, is more time consuming. And even if a patient current hemoglobin A1C is at optimal level, a history of any elevated A1C level is a lifetime risk factor for neuropathy development. Also, you need to check vitamin B12 with preferably methylmalonic acid. So it's important to screen for elevated methylmalonic acid with B12 to increase sensitivity of detecting clinically relevant deficiencies. And if you found a level of B12 less than 350 or elevated methylmalonic acid, then you need to give some supplement. The last test that you routinely need to order is the thyroid function test, mainly the thyroid stimulating hormone. Further testing includes serum protein electrophoresis if you are expecting or suspecting paraproteinemias, which account for about 10% of peripheral neuropathy, like lymphoma, multiple myeloma, cryoglobulinemia, etc. The electrodiagnostic testing, like EMG, is not always recommended, but it can confirm the presence of large fiber peripheral neuropathy and determine whether it is axonal or demyelinating in nature, and maybe more importantly, rule out other differential diagnoses like radiculopathy. Nerve biopsy and skin biopsy rarely needed. Um, be thoughtful when you consider nerve biopsy because even if you do the sural nerve, there is a risk of persistent nerve damage, and per se, it can cause peripheral neuropathy. Skin biopsy is a reliable diagnostic tool to confirm small fiber neuropathy. Other laboratory testing really depend on what you are expecting. If it's inflammatory disease, you can add ESRC reactive protein. If it's metabolic syndrome, add another examination here. The liver function usually under the CMP, but if you are expecting toxins or infections, you can do some urine samples. Nutritional deficiencies, Lyme disease, you check for serology, and then mediastinal mass, you can check X-ray, intermittent acute porphyria, gamma amino levolinic acid, etc. Lupus, Sjogren, check anti-nuclear antibody, celiac disease, specific antibody, paraneoplastic syndrome, specific antibodies, motor neuropathies, you can check for anti-GM1 immunoglobulin, Guillain-Barre antibodies, others, etc. So let's switch gear and talk about management. First step in management, you need to do risk factor modification. So intensive glycemic control has shown to be significantly delay the development and progression of neuropathy. Extremely important. And beside glucose control, you need to do lifestyle interventions, particularly diet and exercise. Coupled with adequate lipid and blood pressure control, these are optimal therapeutic approach for patients with diabetes neuropathy. Of course, you stop alcohol and optimize any malnutrition related to that. Especially with alcohol malnutrition, you need to think about thiamine and folic acid. So every time you have peripheral neuropathy, you need to think about risk of fall, risk of foot ulcers, and you need to think about how you prevent that. Because remember, the patient doesn't feel. So they doesn't feel, they can injure their foot without even knowing how they injure it. And especially if they have large fiber neuropathy, they can have balance issue and they can fall. So you need to think about that. And often in these cases, you need to refer this patient to physical therapy, specifically for exercises and training to increase ankle dorsiflexion and knee extension, strength, and balance exercises. And you might need to use a cane. Foot ulcer, extremely important to take a lot of precaution about the foot. So especially recommend for the patient to wear shoes or protect their foot inside and outdoors. And then I cannot stress on this anymore. You need to set treatment expectation. This is a chronic disease, progressive disease. Unfortunately, it's incurable, especially at certain point. So the goal of treatment is to prevent progression and to minimize the amount of symptoms to a tolerable level. So let's talk about pharmacological treatment. Generally speaking, the anti-neuropathic medication can be divided to antidepressant, anticonvulsant, and opioid. It's very important to have that discussion with the patient, especially when they think, oh, why you are giving me antidepressant? Do you think it's in my mind? So explain this to the patient that these are good medication. I will show you a few slides to prove that. An antidepressant, generally speaking, can be separated to tricyclic antidepressant and selective serotonin and noradrenaline reuptake inhibitor. So the tricyclic antidepressant TCA, like amitriptyline, nortriptyline, desperamine, the SNRI, duloxetine, venlafaxine, the anticonvulsant, you have plenty of them. Gabapentinoid, valproic acid, topiramate, carbamazepine, oxcarbazepine, etc. And then, of course, you have the opioid that you should not use unless really necessarily. And tramadol is a good example here. So when we think about pharmacological uh, medication, I want you to think about this slide because when it comes to neuropathic pain, there is a bunch of targets, receptors, channels. So NMDA, sodium gated channel, calcium, potassium, even serotonin, adrenergic receptors, GABA receptors. So all of that multimodal you need to think about. So having said that, when we talk about the TCA, specifically the amitriptyline, for example, and its group, so look how many receptors actually it work on. So it work on the serotonin receptor, the noradrenaline receptors, it work on alpha adrenergic, histamine, muscarinic, NMDA, sodium, calcium. Similar thing when we talk about desperamine. So it's another potent medication. SNRI, like duloxetine, venlafaxine, not that much of receptors, but still, that doesn't mean they are not good or not potent. Now, I really like this illustration. So this introduces a concept that we need to know. It's called the number need to treat. So what's number need to treat? It's basically defined as the number of patients needed to treat to obtain only one patient with 50% pain relief. So responder defined as 50% pain relief. So in the x-axis here, you see the number of patients you need to treat to get one patient with 50%. And of course, you would be interested in things like, let's say, less than 5. So if we look at less than 5, we are talking about this group of medication. Tricyclic antidepressant, carbamazepine, or, gabapentinoid, and duloxetine. So these are the more potent medication. This table also present the same concept with different numbers, and they even subdivided that to neuropathic pain and painful diabetic neuropathy. We're not going to go over these numbers in details, but what I want to bring to your attention, for example, is let's think about this pregabalin. So the number need to treat, if you are giving 300 milligram daily, is higher than the number need to treat if you are giving 600 milligram daily. Why this is important? Because with this medication, the dose is important. So you cannot, for example, give the patient 50 or 100 pregabalin and call that didn't work. You really want to titrate up to a therapeutic dose. And as you see, the more you go up, the more you go therapeutic, the lower need to treat to be. So it's an important discussion with the patient and concept to keep in mind when you are dealing with these medications. And then another important concept when we are dealing with this medication is something called number needed to harm. And this is defined by the number of patients that need to be treated for one patient to drop out, which means stop the medication due to a specific adverse effect. So here we're talking about therapeutic dose. So for example, let's look at the first line, dizziness. So I need to treat 4.5 patients. So one of them will stop the medication because of dizziness. That's with a 300 milligram dose. While obviously, if I increase the dose, I don't need that much patient. I need 3 patients. So from 3 patients, one of them will stop the medication because of bad dizziness. And you see, for example, duloxetine, which is one of my favorite, if you use it at 60 milligram, you need like 20 patients, more than 20 patients. So one of them will stop using it because of dizziness. You see the somnolence, you see the nausea, you see the constipation, which makes sense. Constipation, less patient need to be treated to drop off because of constipation with opioid compared to pregabalin and gabapentin, for example, which it doesn't cause constipation in most of the patient. The last concept I want to introduce when you choose among the first line medication, again, these are the first line medication, the SNRI, the duloxetine, venlafaxine, TCA, gabapentinoid. So you need to think about the comorbidities that the patient have that favor your choice, or you should not use it because of that comorbidity. So for example, if your patient have depression and anxiety, boom, that duloxetine. But if the patient have a sexual dysfunction and that's a big thing for them, that's a question mark. Let's take another example. If your patient have cardiac problems, QTc prolongation, etc., urinary retention, then avoid TCA. If your patient have peripheral edema, chronic obstructive pulmonary disease, then avoid gabapentinoid. If your patient have restless leg syndrome, boom, that will be gabapentinoid with this peripheral neuropathy. Okay, I will wrap up with interventional pain management. And this is not in-depth review. This is just to highlight, to show you that there are something there worth considering and talking about. So neuromodulation is a big thing, really big thing in pain management. And when you talk about neuromodulation, it can be peripheral nerve stimulation, dorsal root ganglion, it can be spinal cord, deep brain, etc. So obviously, this is a single lead that's treating a single nerve. So in this case, it's behind the knee, so maybe the common peroneal, the tibial. So this is a useful modality if you have a mononeuropathy. Obviously, it's not going to work if you have pain diffuse in both feet. And you also can consider radiofrequency neuromodulation, but that doesn't last long enough. The other option, which is very good, it's very good with a reported number need to be treated really good compared to the pharmacological medication, but I don't want to overwhelm you with this information. But for example, spinal cord stimulation, see, this is a dorsal column stimulation, and it's an FDA approved since 2022. Actually, multiple companies get that approval so far. Check out this technology, very important, very helpful. Another technology is the dorsal root ganglion stimulation. So this lead at L5 and this lead here at S1 really cover the foot very well from up and down. And this is another useful and important, very potent, really, technology. Another thing to think about is the capsaicin 8% patch. You're thinking capsaicin spicy pepper. That's absolutely right. So it's from the spicy pepper. It burned the nerve endings. And there are a bunch of studies that shows its usefulness. And it can be applied as an outpatient clinic procedure. Further intervention to keep in mind include the ketamine and lidocaine infusion. Again, this need a whole lecture by itself, but it's worth exploring, and there is a growing evidence for that. So let's wrap up and put things together. It's not really an approach that I can claim, but I really put things together that help you to understand how we approach management here. So you have a peripheral neuropathy, painful peripheral neuropathy. you need to absolutely do control of underlying cause, of course, if you can. Think about prevention and start the first line pharmacological treatment, as I showed you: amitriptyline, duloxetine, gabapentinoid, etc. Now, here's the key thing: you need to give it enough time, titrate it gradually. Give it enough time, usually a few weeks, few months before you call this is a failed medication. And usually, sometimes it's a trial and error. And it's very important to set the realistic goals with your patient. If that's not enough, then you go to what I call it the second line. And I put it here in red because this is really a growing area. We're still expecting more research. We still need more research, at least to come up with a clear algorithm for this patient. But here I put or, because you either can try other medication, from this I mentioned, um, maybe, add to the whatever you have in the first line, maybe use some opioid, that's a discussion with the patient based on comorbidities, etc. Or really consider neuromodulation, which can be very potent and important modality. And of course, the capsaicin and the ketamine lidocaine. But neuromodulation, I think, is the future from now on. So thank you for watching. I hope you found this helpful.